So the biliary system is a network that drains bile from the liver to the duodenum. Yes, bile comes from the liver. It includes the gallbladder, the cystic duct, the common hepatic duct, the common bile duct, sometimes also called the CBD. The gallbladder essentially acts as a storage unit, concentrating bile between meals and contracting when we eat to release the bile into the intestine for fat digestion. So if you've been on the floors or wards, you would know. Generally, people with gallbladder pathology, let's say cholecystitis, they usually are exacerbated by after they eat a fatty meal. Why? Your body eats fat, you need to release bile. Your gallbladder contracts and squeezes, but you may have a stone or some type of obstruction, thus pain after a fatty meal. And because of this contraction, when we eat fat, problems that can occur when flow is interrupted can be stasis, infection, and as a result of stasis itself, you can get stones. Stones can also cause stasis, but stasis can also cause stones. So these all belong to the family of gallstone disease. So a little bit of an overview of gallstone disease. There's 4 major disorders. Cholelithiasis, which is gallstones in the gallbladder. Choledocholithiasis is stones in the bile duct, particularly the common bile duct. Cholecystitis is inflammation. It's just the word we use for inflammation of the gallbladder. And cholangitis, the most severe of them all, you can think of as an infection of the biliary tree. The stone gets stuck, you build up stasis, bacteria start to spread, and you get Charcot's triad, right upper quadrant pain, fever, jaundice. And if you add hypotension, altered mental status, then we call that Raynaud's pentad. So you can see this as kind of a spectrum of severity. So let's start with cholecystitis. So in acute cholecystitis, gallstones or biliary sludge block the cystic duct just long enough to cause inflammation and infection. So what do these patients typically present with? They have right upper quadrant pain, fever, and leukocytosis. On ultrasound, you'll see a thickened gallbladder wall, often over 3 to 5 millimeters, and a double wall sign, which you can see here, which is a result of edema. So initial treatment for this generally starts with broad spectrum antibiotics, give the patient fluids, and of course screen for sepsis. Anytime you have an infection or in the biliary system, of course keep sepsis on your differential or something that it can progress to. And I'm sure as most of you know, the gold standard for laparoscopic cholecystectomy is within 72 hours. If the patient also has ductal stones, you can plan a pre or post-op operative ERCP for stone removal. We'll talk about that more in choledocholithiasis, but in some cases, actually most cases, it's helpful to first extract that stone with ERCP from the common bile duct as soon as possible, and then we will remove the gallbladder. So going right into it, as we said, choledocholithiasis means gallstones have made their way from the gallbladder into the common bile duct. And these patients often look jaundiced. They have pale stools, dark urine, pruritus, right upper quadrant pain, which is kind of a common presentation for all of these. And the labs, after you get labs, it's going to show what we call a cholecystatic pattern. So you're going to have elevated ALP, elevated GGT, and elevated total and direct bilirubin. So as I kind of preluded, the best diagnostic and therapeutic tool here is ERCP. Not only does it allow visualization, you can also extract the stone. You can perform a sphincterotomy at the ampulla levator. So you can see here's the stone in the common bile duct, it's dilated. So when you think about choledocholithiasis, you're looking for things like jaundice, pale stool, as I kind of mentioned, and the answer for this, what you want to do is ERCP. And as you can see, there's a specificity and intensity of 95%. So it's a really, really good tool to have. Now, let's start with acute cholangitis. So this is a true surgical emergency. Here, the stones obstruct the common bile duct, just like choledocholithiasis, but now we have ascension of bacteria and affection that rapidly spreads. So patients will spike high fevers, often in the 104 to 105 range, jaundice, high WBCs, and signs of sepsis. Ultrasound might show the double barrel sign, as you can see here, and this just represents dilation of both the common bile duct and the portal vein branch next to it. Treatment starts immediately with broad-spectrum antibiotics. Right away, it's the first thing you do, give your patients broad-spectrum antibiotics, and then do an urgent ERCP. Any delay here can be fatal. Now let's talk about something about gallstone ileus. So this happens when a gallstone essentially erodes through the gallbladder wall. A stone sitting on a wall, or multiple stones, or one big stone sitting on a wall for a long time can cause inflammation, weaken the wall, and the gallstone can erode through it, and this creates what we call a biliary enteric fistula. And this can cause mechanical small bowel obstruction, and it's usually the stone makes its way all the way through until it gets to the ileocecal valve. Now, here on imaging, you're going to see something we call something called Rigler's triad. So there's going to be signs of small bowel obstruction, check. Visible ectopic gallstone, you see the gallstone outside of the gallbladder, check. And pneumobilia, this is a big one, not only for real clinical practice, but on tests. And that's just air in the biliary tree. And we know from looking at CTs of the lungs and everything that air is black, right? So you're going to have, what is Rigler's triad again? Small bowel obstruction, visible ectopic gallstone, and pneumobilia, all found on imaging. So how do we manage this? It begins with NPO. We don't want to give anything else that's going to further move the gut or contract the gallbladder. We're going to give IV fluids. We're going to give NG decompression, and we're going to give antibiotics. And the definitive treatment here is an enterolithotomy with a cholecystectomy and fistula closure. Those are all fancy words for fixing everything that's wrong. Remove the stone, take out the gallbladder, and close the fistula it created. Now, here's a picture of it, just so you can see. The red is pneumobilia, and the green is the colonic air fluid levels. So that's the sign of an expanded small bowel and air in the biliary tract. Now, biliary cancer. Let's talk about biliary malignancies. So the two big ones are cholangiocarcinoma and gallbladder cancer, which can, of course, be squamous or adenocarcinoma. So in cholangiocarcinoma, this tends to occur in men aged 60 to 70, and it's often linked to chronic inflammation or, another tie back to your step 2 and step 3, primary sclerosing cholangitis. So with that said, gallbladder cancer is more common in women, especially those who have a history of chronic cholecystitis or what we would call a porcelain gallbladder. And one thing you want to look out here that can allude you to cholangiocarcinoma or gallbladder cancer is Courvoisier's sign. And this is painless obstructive jaundice with a palpable, non-tender gallbladder. And all these other biliary pathologies we've talked about so far, they have pain involved with touching the gallbladder area, and they also have pain in the right upper quadrant without anything touching it. So like most malignancies, we often like to say that they're painless at first, right? So we have painless obstructive jaundice. They're yellow, and they have no pain, and you can feel with your hands a gallbladder. And while you're feeling this gallbladder that seems like it would be large and swollen, it's non-tender. So these are all red flags for malignancy, not stones. Coincidentally, as I often experience working in the clinic, these are often incidental, generally discovered during surgery or imaging for biliary obstruction. So they may go see their PCP, have signs of cholelithiasis, cholecystitis, and they're going to send you to the hospital. Or if it's cholelithiasis, you know you have stones, you're going to go to the general surgery clinic, and we're going to do the right upper quadrant ultrasound, and we're going to find these incidentally. So here's my references for the presentation. This was very short and sweet. I just want to go back to this side and just touch on a couple more things so we can go over it one more time. cholelithiasis, gallstones in the gallbladder, choledocholithiasis, gallstones in common bile duct, cholecystitis, inflammation in the gallbladder, and cholangitis, the most feared of all, bacterial infection of the biliary tree. Now going back across mechanism, how do we just get stones in general? Cholesterol, biostasis, and impaired circulation. All these things lead to things that can form stones. A lot of stones are mixed. They can be cholesterol. They can be pigment stones. If you've ever taken out a gallbladder and had the opportunity to cut it open after the surgery just to observe the colors of the stones and send samples, you notice that you're going to have some bright yellow ones. You might have ones that are yellow and black. So cholelithiasis isn't actually saying you have something bad yet. A lot of people are asymptomatic, right? So generally, you're going to find, let's say they're at home, they have some right upper quadrant pain. Generally, by the time they come to you or you see them as a surgeon, the pain is generally gone and they're asymptomatic. Now, on the other hand, choledocholithiasis, remember, this is cholelithiasis, we're building on it, this is a stone that formed, and now it's migrated to the common bile duct. Now, in cholecystitis, I'm just going to jump to that quick, you can get that from the contraction of the gallbladder, shooting up the stone as it squeezes, but the stone just hits the entry of the cystic duct, causes a bunch of pain, and then falls back down. So, in choledocholithiasis, this actually goes past that cystic duct and gets in the common bile duct. And this one will have right upper quadrant pain for greater than 6 hours, and I say possibly because we can't say always, but generally these patients are jaundiced. And cholecystitis, as I kind of alluded to, this is from the stasis of stones, and basically to get these signs of inflammation, you can look for certain signs. Right upper quadrant pain, check, that's in all of them, except biliary cancer. And fever, okay, that's a good sign of infection. It makes sense that there'd be fever if an organ's inflamed. And a positive Murphy sign, and you can look at this as you're doing the right upper quadrant ultrasound, and as soon as you touch that probe to the right upper quadrant, they scream, right? It hurts. We call that ultrasonic Murphy sign. Okay, and then one last time, let's go through cholangitis. This is the worst. It's a infection. It's the progression of choledocholithiasis. You could think of it as a progression of first the stones form, cholelithiasis, causes inflammation, cholecystitis, moves past that cystic duct opening. Now you have choledocholithiasis. The stone sits there for a long time, and now you have a climbing infection. That's how we end up at cholangitis. And for this one, the clinical findings to look out for, especially on the test, a lot of these clinical findings down here in red are things that really helped me identify what's happening to the patient really quickly in the question stem. So of course in these patients we have Charcot's triad, right upper quadrant pain, fever, and jaundice. And sometimes you just remember the triad and you forget the symptoms. They're not going to say this patient has Charcot triad. No, the triad is right upper quadrant pain, fever, jaundice. Even more so, they want to add another layer. Always, especially when you're doing surgery shelves and exams, always note the blood pressure. Things change dramatically when a patient is in shock or hypotensive. It can be very clued in. So if you have altered mental status, which they don't always have to give you directly, this can just be something you have to essentially use intuition for, how they describe it. Unaware of his surroundings, not acting like himself, reported by family. So remember that for Raynaud's pentad. Charcot triad plus low BP and altered mental status. Thank you so much, everyone.